Through innovation, academic excellence, and family-centered clinical care, Children's Mercy Kansas City is transforming outcomes for children around the world. Welcome to the audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Welcome to Transformational Pediatrics. I'm Dr. Michael Smith, and our topic is treatment of elevated blood pressure in children. My guest is Dr. Doug Blowey. He is the Associate Professor of Pediatrics and Pharmacology at Children's Mercy and also the Director of the Hypertension Clinic. Dr. Blowey, welcome to the show.
Thank you very much for having me.
So what are some of the challenges that you face in monitoring and treating hypertension in specifically hospitalized children?
Well, there are several challenges. The first one is the most basic one, which is really having a nice way in place or process to identify those children that actually do have high blood pressure measurements. So children get their blood pressure measured multiple times during a hospitalization by various different peoples. And a lot of times they just get put in a computer system, written down, and nobody really identifies when those measures are abnormal and they're not abnormal. So I think the first one is just for the process to be able to recognize when a blood pressure that is measured is actually abnormal.
Right.
As you know, that compared to an adult person where one size kind of fits all, one number is good for everybody, in children we're dealing from neonates, premature babies, to 18-year-olds in our hospital, and blood pressure varies. What normal blood pressure is varies across the age spectrum, and so one size doesn't fit all, and it's a complex process of defining who actually has high blood pressure, and it's a process issue, really. And the second challenge really is making sure that the people that are measuring the blood pressure are doing it the appropriate way. There are clear guidelines about how you should measure blood pressure, and there's a lot of issues that go into the technique of measuring blood pressure that will impact the reading we get. We get concerned that we're getting, when we get high readings, that they're falsely elevated readings because of technical issues, such as we're not measuring the blood pressure in the appropriate extremity. We're not using the appropriate size of the blood pressure cuff to ensure adequate, appropriate measurement. The patient isn't comfortable at rest. You know, in the hospital, we do a lot of things to patients. We cause discomfort, pain. Some of the kids have anxiety because family isn't there, and somebody walks in to do something, they just get upset, and that can affect the blood pressure. So there's a lot of technical issues that we have to overcome to decide if that blood pressure we're getting is actually a true reflection of the patient's blood pressure. So those are probably the two biggest challenges that we have. Some of the things that we've done, and other groups have done too, is trying to simplify, identifying what blood pressures are abnormal, and then again, rather than just kind of writing them down in a chart or putting them in the computer system, that we have developed processes that will allow us to flag abnormal blood pressure values for the patient's particular age and gender. And so you don't have to memorize everything. You can just kind of see that, hey, this blood pressure falls outside normal, and we can flag it for just a little bit abnormal or really abnormal, and then process to identify the doctor based on how many times that happens or kind of the sequence of events that goes from there.
Let's talk a little bit more about measuring blood pressure in hospitalized kids, because in the adult population, I mean, there's studies that have shown that using the automatic blood pressure cuffs that you see all over the hospitals, those are quite reliable, at least in the adult population. Is that true for children, or would you prefer physicians and nurses to actually take the blood pressure themselves?
Sure. Well, as you mentioned, that the oscillometric or the automated type devices are prevalent, and there's a reason, because they're easily to do. It doesn't require much training, and they're fast. The point is that, and the reality is that they're going to be used. That's how it is. However, in children, oscillometric blood pressures or automated blood pressures don't measure the same thing as the old-fashioned manual blood pressure. And the other point about this is all those blood pressure normal values we talked about are actually based on manual blood pressure readings, not oscillometric. And when you look at the difference between oscillometric blood pressure measurements and manual blood pressure measurements, that there clearly is a difference. They don't correlate very well sometimes, and they're all over the place. Meaning it doesn't systematically overestimate or underestimate. They're kind of the spreads all over the place. So it's kind of really hard to know. We kind of feel that if the oscillometric is normal, you're probably okay. But if we have high oscillometric blood pressure measurements, our standard or our protocol is to obtain a manual blood pressure because that's really the gold standard.
Right. And this I think leads into then, so you are part of an international committee, correct, where you're trying to establish some of these guidelines for hospitalized children. Who's a part of that committee? What are the goals of that committee?
Sure.
And how is that going?
Well, it's going well, and it's actually it's an updating of guidelines that have been present. So there's been several guidelines for pediatric hypertension that have been present, and the most recent one, I believe, was like in 1994, 1997, something like that. It's called the Fourth Report. The new group has taken over that. Actually, the National Heart Institute was doing that before, but that's changed, and now the American Academy of Pediatrics has taken over the guideline. And it's a national guideline, U.S. guidelines for blood pressure management. And there's a group of experts, cardiologists, hypertension specialists, endocrinologists involved in hypertension that have published, extensively in that area. And we are meeting to develop new guidelines for hypertension. And what we're really focusing on is there's several very key clinical questions. Rather than being just kind of a comprehensive opinion-based document, we've kind of really focused on 4 clinical important questions. And those questions really are, how should we be measuring blood pressure? What's the optimal way of doing it? And looking in a evidence-based manner. That's one question. The other question is, what should we be really evaluating, or what should the workup be for a patient that is identified to have hypertension? What's the best way to identify secondary causes? The third question that we're asking is, well, if we are treating blood pressure, what's the optimal goal? What's our target, and why is it that target? And then finally, we're trying to look and find what evidence there is that treatment, whether it be lifestyle modifications, dietary, exercise, other things, or medications, what is the evidence that it really decreases the indirect measures of cardiovascular risk? And this is an important point in pediatrics. In the adult world, the outcome of death and cardiovascular disease is very prevalent, and so you can do studies and look for those outcomes. Fortunately, in kids, they don't have those outcomes. And what we know is that although they don't have those bad outcomes, we are seeing early development or the early pathogenesis of atherosclerosis and cardiovascular disease in kids, but in indirect ways. So looking at thickening of the heart or left ventricular hypertrophy, looking at thickness of the intimal vessels of the carotid, looking at some physiologic flow characteristics of the peripheral blood system. The blood circulation system. So we look at those things, we see changes in kids that have hypertension. So we know they're the kind of surrogate markers. And so we're trying to say, is there any evidence that when we do things, does those improve? So those are the 4 key clinical questions we're developing and developing some statements for the practitioner.
Is there a timeline that you anticipate having these new guidelines published?
Yeah, so right now we're in the phase of extracting, all the literature. We've developed those questions, extracting the literature. Then we'll work on putting some consensus guidelines together. So I think we're hoping that by this fall that they will be ready for publication.
Dr. Blowey, I want to thank you for the work that you're doing. Extremely important, and the success you're having and that Children's Mercy is having is really impacting, the daily practice and improving the health of children. So thank you so much for that. And I want to thank you for coming on the show. You're listening to Transformational Pediatrics with Children's Mercy Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.